Yeah, thank you for the kind introduction, and I thank the organization for the invitation today. I was requested to talk about implementation with a particular focus on organizations or organizational aspects. So I will not so much focus on guideline implementation as such, but I think many of the messages apply to guideline implementation as well. My background was already introduced. I am from the Netherlands. I'm Dutch by background. I worked in the Netherlands for many years, but since 2 years I moved to Germany to be Professor of Health Services Research and Implementation Science. I lead a small master program for this field with 20 students per year, each year. Other relevant roles are Editor-in-Chief, it was already mentioned. I'm also associated with the Cochrane EPOC group, which focuses on implementation research. If you are interested in implementation or improving healthcare practice, this may be a very useful source for you as well. And I remain related to my previous department in Nijmegen. My background is in sociology, but I'm not sure if I'm a sociologist anymore, because since then all my further degrees are in the medical sciences. And finally, I don't think I have any conflicts of interest to report regarding this particular talk. So this is how Heidelberg looks like, at least in the summer. We also have snow occasionally. So I have structured my talk in basically 3 parts. I will give a general introduction to the field of implementation science from my perspective. I brought 3 examples of organizational changes which I will present. They are not related to rehabilitation, but I think there can be lessons in these examples for you as well. And then I will talk, elaborate a little bit on theory, on organizational change, and give a brief outlook. So first about implementation science. The field started, I think, about 20 years ago, but about 10 years ago we started the journal Implementation Science, and in the first editorial, Martin Eccles and Brian Mittman defined the field as follows. It's the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and also in policy, by the way, and hence to improve the quality and effectiveness of health services and care. So it's very much about implementation of evidence-based practice, but we see this in a very broad sense. It's also implementation in policy and also other parts. We have this particular idea that it is useful to make a distinction between 2 things. On the one hand, research findings, on the other hand, the implementation. So research findings or evidence relates to treatments, devices, but may also relate to organizational models like case management or health system reforms even, which have been tested and shown to be effective for patients and populations. And the implementation relates to the bringing this into practice with a focus on strategies to enhance the uptake of the research findings. And these strategies can be educational, organizational, financial, or political. And the particular idea is that it is useful to make this distinction. So to give a few examples, one example is antibiotics prescribing in mild respiratory diseases usually does not have much benefit, and this may be implemented. This has been shown in clinical studies, clinical trials, and the implementation strategies may be continuing education and computerized decision support. The second example is structured diabetes care. So this is a sort of organizational model, if you want, has better outcomes than standard care, and this may be implemented through financial incentives and also by increased involvement of nurses, for instance. These are examples of strategies. A third example relates to shared decision-making in oncology. The studies studies show that if shared decision making is applied, decisions are more aligned with patient preferences. This is also a sort of evidence, and this may be implemented by various methods of patient empowerment and also by the involvement of clinical opinion leaders who promote this idea. So these are examples that illustrate how we look at things. In practice, it's not always possible to say exactly what is the implementation program and when it has started. This will be the case in the examples that I will present shortly as well. Second point, this is, so far I've presented it very black-white, but in reality there's often a mix of evidence-based and less evidence-based or non-evidence-based elements. Even many clinical guidelines have components which are strongly evidence-based and components that are less evidence-based. And this is even more the case when the focus is on organizational changes. And third comment is that you could also say that in some situations a successful implementation is a condition to have any impact on patients and populations at all. If the intervention is particularly complex, the implementation may be the first challenge you have to address. If you want to restructure healthcare completely or implement information technology systems that are completely new, the implementation of this is the first challenge and crucial to be successful in order to achieve any impact and in fact to study the impact on patients and populations. To elaborate a little bit further on the field of implementation science, what are domains of research? We study dissemination of knowledge, so which can be guidelines or technologies on innovations. How do you inform various target audiences? We study factors that influence diffusion and implementation. These are often called barriers and enablers for change or for implementation. Of course, we study the design and evaluation of implementation strategies regarding effects and also costs and also processes. And last but not least, we also study the scale-up and sustainability of implementation, although the number of studies on this topic is relatively low. Dissemination strategies, what are these? This is not rocket science. You can probably mention a few yourself. This is about publication in scientific and professional journals or books and reports, lectures for various audiences, press conferences to reach the media, and also the use of social media to reach followers or members of particular platforms. Could be a dissemination strategy. Implementation strategies can be categorized in different ways. The Cochrane Group EPOC has a particular list of strategies, and this list is slightly different but related. I would say that continuing professional education is one major strategy, method to implement research findings, and it has several formats and several modalities. Feedback, so meaning data collection, audit in English, and giving feedback to clinicians about test ordering or prescribing or outcomes of patients. Outcomes for patients is a second large category of methods that is widely applied in many settings. Computerized decision support, starting with simple reminders, but up to very advanced decision support tools. Various strategies for patient empowerment can help to implement certain findings. It also serves different purposes, but it can also help to implement knowledge in practice and policy. Various sorts of organizational changes, involvement of nurses, different structuring of teams, different leadership, etc., can help to implement things. And of course, financial incentives, and last but not least, laws and regulations. I noted that the ideas about how to think and how to approach implementation varies a lot. Somewhat simplified, you could say it varies between countries. I worked for many years in the Netherlands, and in the Netherlands, the implementation is a field which emphasizes education and support of practitioners. So they need information, they need modern types of continuing education, they need feedback, and they also need practical support. This was the dominant idea in the Netherlands for many years. In Germany, this is very different. In Germany, if you start talking about implementation, the first response is we have to pay. It's about payment. Without payment, the assumption seems to be that without payment, nothing will happen. And they also talk about laws and regulations. You have to make it something obligatory. In addition, there's also continuing education. These are the two countries I know best. England, my perception is that there are many top-down programs led by the ministry, and these programs start suddenly and are stopped suddenly, usually when there's a new political party in the lead. On the other hand, there is also a lot of talk about, and also examples of projects that emphasize stakeholder involvement. In the United States, you can, for instance, see many initiatives of quality improvement, which emphasizes leadership and measurement, so feedback, you could say. And in Canada, the field is not called implementation science, but knowledge transfer. And this is about focuses on the generation and dissemination of knowledge in relation to primary research. So I don't know exactly where you would position Finland here. This could be an issue for discussion later. There's broad consensus in the field that you should ideally take a stepwise approach to systematic implementation and also a tailored approach. There's not one approach that fits all purposes or all settings. There's no magic bullet. Andy Oxman wrote already 20 years ago. But you have to ideally take a stepwise approach, specify your goals, analyze the context, the organizational and also the cultural and financial context, and analyze the interest of stakeholders, then try to understand the implementation problem. This is all preparation and all exploration oriented. And then you choose and apply strategies, evaluate them ideally, and adapt them if necessary. You may also have to adapt your goals if they were too ambitious, or perhaps they have been reached and you can set different goals. I already mentioned the journal that I am involved since the start, and editor-in-chief together with somebody from the United States and sales since a few years. The field has developed enormously since we started. This is illustrated by the number of submissions we get and also the number of publications, although we publish a little bit more than in the beginning, but not so many more. Most submissions are actually from North America, the United States, and also from Canada. Second largest is England, United Kingdom, and less submissions from other countries, and actually few from Finland, I think. So you are encouraged to submit your papers if you have papers in the field of implementation science. Of course, in the end, the purpose is to support healthcare providers or decision makers. They could also be managers or politicians. Here you see one of my colleagues in Nijmegen, Wim Verstappen. He is a GP, and you see him in his practice. You see that he has lots of information around him. He has a computer, because there are computerized medical records. There's also computerized decision support in general practices in the Netherlands. He writes probably a medication for a patient. He has a manual, and he also which contains advice on pharmacotherapy. And you see various measurement instruments. So he has lots of information. So it's easy to imagine that he may forget something occasionally or do things that are perhaps not recommended. So our role as implementation researchers is to support him and similar decision makers. Then moving to organization. What has organization to do with implementation? Well, in three ways, I would say. First of all, organizational change is a category of implementation strategies itself. For instance, if you want to implement diabetes guidelines, you may reorganize your practice and involve nurses more actively in the care of diabetes patients. You may, and this could be called an organizational change, which is then a method for implementation of the diabetes guideline. Secondly, organization is needed for scale-up and sustainability. Also, if the intervention is not organizational. For instance, if you want to organize feedback for all providers in a specific country, you have to organize this. And this is also an organizational aspect. And third, organization is, of course, a context in which implementation happens, and the context is likely to influence this. Then I come to my examples. Before I do this, a word of warning. There's not a lack of negative studies in this field. As an example, we studied the implementation of diabetes guidelines many years ago. In the Netherlands, we surveyed 83 providers, physicians and nurses in 30 practices, and we also collected data from patient records. And our measures in the survey concerned the team climate, how well the cooperation between doctors and nurses were. We also measured organizational culture, the ideas, shared ideas particularly about innovation and working together. And as I said, we measured aspects of diabetes care. We found, however, few associations between the two, between team climate and organizational culture in these practices on the one hand, and clinical patient outcomes on the other hand. There were a few exceptions, but they could be based on random findings. On the other hand, many people perceive, and I also think, that organizational context can be highly influential and is highly important. This is illustrated, for instance, by this study in which, in the United States, in which primary care providers had to implement certain things, and then they were surveyed, they were interviewed, and they mentioned a range of factors that they perceived to influence the uptake of these guidelines. So probably it's important, but it is difficult to point out exactly what are the context factors. But then now, because I don't want to bring you only negative news, I bring also some relatively successful examples of organizational change, at least. The first example relates to Germany. It's in the region of Baden, the federal state of Baden-Württemberg. This is in the federal state in the south of Germany, which has 11 million inhabitants. I was reminded about the number of inhabitants in Finland, so this is quite a highly populated region, although it also has very rural areas where the nearest hospital is 100 kilometers away. So the aim was here of this particular program to strengthen patient care for patients with chronic diseases. This is a long-running initiative since 2007. So next year there will be a conference to celebrate the 10-year of this program. And there was evaluation related to this based on administrative data. The program can be described in different ways. This is one way to do it. There was leadership from the beginning, particularly regional GP organizations and health insurers, meaning the largest sickness fund in the region, AOK Baden-Württemberg, supported the program throughout over the 10 years. The whole thing is non-obligatory for both patients and GPs. They don't have to participate. However, there's reimbursement associated. If you participate, GPs get better reimbursement, and there are also benefits for patients. The team approach is very much emphasized because the role of the practice assistants is strengthened. This is traditionally not so strong in Germany. There are specifications of the equipment that has to be in the practices if you want to participate as a general practice. The collaboration with ambulatory specialists is better arranged. And there is feedback. So there's feedback in the context of quality circles, so-called quality circles. These are small groups of doctors, sometimes also pharmacists, who get feedback on, particularly on prescribing, medication prescribing, and then make plans to improve their performance. One evaluation after 5 years showed that this had some effects. So there were more visits to the GPs. There was more medication prescribing. Difficult to say whether this is good or bad. But there was fewer medication that should be avoided. Fewer referrals to specialists, fewer hospital admissions, and also fewer days in hospital. So the ambition was to strengthen primary care, and this seems to have been achieved, at least. The development is in that direction. Comments. This is, of course, a complex program. It has many components, and it's difficult to say what is the relative importance of several components. In Germany, people emphasize the reimbursement part. They say it was crucial that doctors get more payment if they participate. I would also emphasize the support part, but perhaps this is my background from the Netherlands. In reality, this is all speculation because there's no evaluation so far focused on understanding the organizational or context factors. This is not covered by the evaluation so far. This was one example. The second example, I first present the examples without much discussion, is the physician assistants in hospitals. This is, you could say, a major or as an organizational change in hospital wards or in some hospital wards. It implies that medical care in wards is provided by non-physician clinicians, so typically nurses, sometimes physiotherapists who get additional training at a master level. And this role is traditionally and still taken by young doctors as part of their internships. But in some departments, this position of physician assistant has been created, mainly in surgery and internal medicine, it seems. There was not much research around it, so you could not say this is an evidence-based idea. We did a study. It was difficult. It was not feasible to randomize. So this is a comparative study in 34 hospitals. And we had length of stay as primary outcome. This can be discussed, whether this is a good outcome, but this is what we had. And there was no change of length of stay between models that used this physician assistants, and there were also doctors involved. So it's actually a combined model, doctors plus physician assistants versus only medical doctors. There was also no indication that quality or safety was improved or worsened. However, there was some indication that patient experiences were slightly better. I already mentioned there's very little evidence on this example. It's highly controversial. It's highly debated. There's, on the one hand, strong believers. On the other hand, strong non-believers. People, particularly medical specialists, who really believe this is not a good idea, but there are also specialists who believe this is a good possibility. So in the end, it's very much a local decision. Whether physician assistants are implemented is very much dependent on the decision of a hospital department or the group of physicians that leads a particular department. If they want it, then it may be implemented, and if not, then not. The national conditions have been arranged, so this new group has been recognized. It is allowed what they do. They can diagnose, because their role is to diagnose certain things and also prescribe medication to patients. And this has now been legally made possible, and also the reimbursement has been arranged. So there's no formal barriers, so to say, but the real implementation depends very much on the local situation. Then the third example, This is the example of out-of-hours care in the Netherlands, or primary care, out-of-hours care in particular. This is not really a program, I would say. But nevertheless, there's a major organizational change in the last 15 years. The current situation is that out-of-hours care, primary care, is provided by about 120 general practice cooperatives to most people in the population. In the Netherlands, the population is 70 million. So typically, one cooperative takes care of 100 to 150,000 inhabitants, and typically about 100 GPs are connected to one cooperative. If you contact this cooperative, a nurse will be the first contact. They do triage by telephone, typically, and then they may give advice by telephone. They may or arrange a consultation or a home visit, which is usually by a doctor, or almost always by a doctor. The program is older, but I report here the latest developments. So the current development that is going on is that these primary care cooperatives are integrating with hospital emergency departments in the last 5 years. And this is a development that is still going on. And also a major development is that there's now access to patient records in these settings, records that are in primary care practices. So patients had to give informed consent, and then they have access. Third, there are experiments with direct access to laboratory services and also with advanced nurses who, in these experiments, they do some of the consultations and home visits. And there's a small dedicated training program. So this is very much an incremental program, many small steps and adaptations. It's not really implementation of evidence-based practice, but it's actually a response to perceived problems in healthcare. In the end, this solves or has the ambition to solve a problem, the problem that GPs were not so enthusiastic to do many out-of-hours services anymore. So after this reorganization, they have to spend less time during out-of-hours. So this was one ambition, and this has been realized. I think it's also worth mentioning that in this field there are clear opinion leaders. One of them used to work with me in the Nijmegen department, and he and others very much drove this development forward and also did research around it. So this summarizes the projects so far, but I think I will move on to talk about organizational theory. So why about theory? Bother about theory in the first place? For researchers, theory is important to guide the research, of course, and also to develop knowledge in a systematic way. If it's a good theory, of course, it's helpful. But for the practitioners, theory can be attractive because it makes a lot of knowledge accessible if the theory is valid. Nothing is so practical as a good theory. In implementation science, we have lots of theories, perhaps even too many. Here you see some listed. I will not discuss them all. These are some popular ones. You could say, somewhat simplified, they cover a range of issues. So there's theory about evidence, how this should look like, and how guidelines can be made more attractive and more likely to be implemented. There's theory about individual cognitions, psychological theory. The traditional diffusion of innovations theory emphasizes very much the role of social networks. But there's also theory that emphasizes what you could call culture or social processes. There's, of course, economic theory that emphasizes incentives. And there's organizational theory, or at least hypothesis, that's very much about systems. There are also efforts to summarize across theories all these ideas. Actually, there are many efforts. We have over 60 frameworks for determinants of implementation. Here you see one effort in which I was involved. It was led by a Norwegian group, Signe Flottop and Andy Oxman, who developed in the context of an European project a TICD checklist. we analyzed many existing frameworks, including several that I listed, that I mentioned. It's focused on barriers and enablers, and included in the end 57 concepts in 9 domains. This is what it looks like. So these are a sort of menu of factors, or they call it a checklist, I call it a framework, of factors which may influence the uptake of implementation. Not all factors are always important, of course. In some situations, the emphasis may be very much on individual factors, cognitions. In other situations, the focus may be much more on organizational or political factors even. But there's a wide range of factors that potentially influence the uptake of new research findings. And I will elaborate a little bit on some of the organizational theories that may be relevant for implementation. I will have one slide on each of these 5 theories. Some relate to systems, some to actors. So perhaps you may or may not know the chronic care model. This is an idea from the United States. It's basically a list of factors that influence the uptake of chronic disease care. It emphasizes that work processes should be optimized, that evidence-based guidance should be accessible, that patient self-management support should be well organized, and that coordination of care should be organized. And all of this should be embedded in a supportive environment, so community and health system. The model, I mention it also because this model has been quite influential in the last decade, I would say, at least in primary care and in the Netherlands, but also in Germany. It's quite a popular model and framework or theory for policymakers. A second example is the competing values framework. This is about organizational culture. And there's a questionnaire associated with it. The theory and the idea is that culture can be more flexible or more stable, and it can be more inward or more outward looking. And based on this idea, 4 types of organizational cultures can be distinguished. So in primary care, in general practices, there's often a clan or family culture. This is a type of culture which is characterized by cohesion and tight networks. In hospitals, you also see, particularly in hospitals, occasionally also in primary care, you see cultures that are more hierarchical or are more market-oriented, which have different aspects, different characteristics. The adhocracy in this framework is the culture you typically expect in a startup firm, is less prevalent, is not very often seen in healthcare. So this is another organizational theory, and a third which relate to systems, and this also relate to systems. It's called organizational readiness for change, proposed by Brian Weiner, who's also associated with our journal as associate editor. Individuals can be ready for change, but the argument here is that organizations can also be more or less ready for change. And ready means willing and able, so there has to be commitment and there has to be a perception that change is possible, change efficacy. I mention it also because it's one of the highest cited papers in implementation science. For some people, for some reason, this is a very attractive idea for many people. Then there are theories that emphasize the role of individuals in organizations. I didn't identify a very clear theory about leadership, but I found a very helpful overview paper by Craig Aarons, also associate editor of our journal. And he says leaders can influence practice in many ways, in what they pay attention to and measure and control. That's emphasized, how they react to critical situations. Not only the direct this has not only direct impact but also long-term impact, because it shows what is important and what is less important. Of course, how they allocate resources. Of course, role modeling, teaching, coaching is another way to have impact as a leader or manager or policymaker. How you allocate rewards and status. This is not necessarily resources, but a similar idea. And of course, how you recruit, select, promote people, or perhaps communicate people occasionally in your organization. And then the last theory or set of theoretical perspective I briefly want to mention is the network perspective. People are connected in social networks. Healthcare providers and managers also are connected in networks. And these networks, the structures and the characteristics of these networks influence many things, many behaviors. First of all, they may help or not help to navigate to particular resources, for instance, to people with knowledge or to people who can provide specialized things. The network structure also influences negotiation processes, for instance, in the context of referral of patients or finding a place in a nursing home for a patient. Negotiation is an important thing, and this is influenced by characteristics of networks. And the second line of thought is contagion, that this is the idea that in networks, ideas and also behaviors spread because people influence each other. It's almost like infectious diseases. Because of psychological mechanisms, people have the tendency to imitate at least people who they see as successful. And this is also influenced by networks. So this is a third idea within this network perspective. This summarizes it in words. I would argue that these actor-specific concepts, so on leadership and networks, may be directly relevant for particular change, while the system-related concepts tend to have indirect impact, but potentially on a wide range of changes. Then, of course, the challenge is to bring this all together, and this is very tentatively. I try to bring it together, but it could be discussed. I think in the case of primary care, general practice in Baden-Württemberg, it's clear that the chronic care model was quite a dominant idea. So the idea of strengthening general practice care, particularly for people with chronic diseases, was based on this chronic care model, and they more or less systematically try to implement it. I think also professional networks play a role in this setting, although it was never studied, because not all GPs take part. About 4,000 of 8,000 GPs in Baden-Württemberg take part in this program. And I think whether they take part or not is partly influenced by what their colleagues do with whom they are connected. This is an hypothesis, could be studied. In hospital settings, I think the culture and the organizational readiness for change and also leadership behaviors are more dominant. In primary care, this may also play a role, but because this is largely in relatively small practices, at least in Baden-Württemberg, perhaps the practices in Finland are a little bit larger, so the system factors may be more relevant here than in these very small office-based practices. So I would argue they are certainly relevant in hospital settings. In out-of-hours care, partly, I'm not sure whether culture is so relevant because this is a very particular setting. The GPs work in an out-of-hours organization for 2 nights per month. And then there are a number of nurses who work there more regularly, but this is like a pool of people. So I'm not sure to what extent there's really a culture that is developed there. But as I said, this is a tentative attempt to bring this together. Some concluding words. It's not all a positive story that I bring. Unfortunately, I cannot really say you should do this or that and then you will have successful implementation. Some have argued the world is perhaps too complex for science. The organizational world is too complex to understand. So this explains the many negative findings that we have. I would say more positively there's work to do for researchers and practitioners. It may be, so first one slide on research. it may be noted that it's not always clear what is the program of change, where does it start, where does it end. There's also a mix of evidence-based and non-evidence-based components, and this is not really clearly disentangled. So I would say a good idea seems to me to, first of all, to describe and analyze these complex organizational strategies in more detail in so-called logic models, in which you disentangle how these different components are brought together and also how they are supposed to influence something. And an initiative like the teoriaa checklist, which is now implemented for research papers that are on interventions, is, I think, a very good idea, because at least it forces researchers to describe the programs and strategies in more detail. A second reflection that I have is that this whole line of research on contextual determinants, so factors in the setting that influence the uptake of research findings, is not very successful so far. There's not many correlations, so I'm not sure whether this is the way forward. At least I think we need more dynamic frameworks, because it's typically correlational. There's a set of factors in the culture or in the system or in the finances, and on the other hand a set of outcomes. But you could imagine that some factors are important in the beginning and other factors are important in later stages of an implementation process. But there are not many examples of studies that look at this in this way. Then for practice, I noted, I think the examples suggest that many of these complex programs are developed over time, sometimes over a long period of time, 10 years or 15 years, incrementally, with continuous adaptations and changes. And the so-called decisive evaluation, there's one large study, and then you decide, some decision maker decides whether this is implemented or not, does not really apply. There's never been a large study on out-of-hours care in the Netherlands, and also we did the first study on physician assistants, but it is unlikely to bring about a decisive decision or a decision whether physician assistants should be implemented or not. Second point, this is of course related, is that it can be observed that opinion leaders and also shared opinions about something have major impact on the implementation in organizations. And this leads to my hypothesis that the preparation for an implementation activity is probably very crucial for successful implementation, because in the preparation you try to first identify different views and different interests, and then try to find consensus or try to find a way forward at least. And perhaps this preparation phase has been underestimated so far, at least in my world, in the world of research. It usually starts when the program is ready, the strategy for implementation has been developed, and then we start with evaluation. And perhaps we should focus more on the preparation phase. That would be my hypothesis, and actually also recommendation. And the preparation for a larger program may actually take in itself 1, 2 or 3 years. So far my introduction and brief overview. I hope the examples are helpful to you, although they do not relate directly to rehabilitation. And thank you for your attention.
Well, thank you for an excellent overview, and I'm sure that we now have several questions and comments on this presentation, and we also have nicely time for that. Yes, Marjukka Mäkelä, please go ahead. Please wait for the mic because of the distant people that are here with us.
Thank you. Thank you, Michel, for an excellent presentation, and you showed us how a rich description of what we are trying to do in implementation is essential if we want to understand what is going on and why. My question to you is, when we are writing the articles about implementation, should we move from the epoch checklist to the TICD checklist instead?
Yeah, no, I would not recommend this. The TICD checklist lists factors that influence or are supposed to influence implementation outcomes. So like positive attitude, favorable, also a well-functioning team, a well-organized reimbursement system. Some of these factors could be seen as strategies, but the epoch list focuses really on strategies, that is, things that have a clear starting point, and then they are done, like a continuing education program or a pay-for-performance program. However, I think the epoch checklist, particularly the latest version, is not very helpful. So I recently joined the epoch group, but the other members already said that they would be happy to review the checklist, because I actually find the old checklist better than the new checklist for implementation purposes.
So which one should we use?
I think both. Both are relevant, yeah.
Okay, Matti Rautalahti, wait for the mic, please. And then.
You mentioned different approaches, national strategies, how to forward implementation or how to practice it. And one of them was the Canadian model using knowledge transfer. And of course, knowledge transfer is a very tempting approach because it's, how should I say, relatively easy, so to speak. You just pass on the information and you expect the recipients to act accordingly. But what does the evidence actually say about the impact of knowledge transfer when it comes to implementing something you want to happen or done in the real world?
Well, first of all, I would say that dissemination and getting exposure to knowledge is a logical first step to any change. Because you have to understand what is expected, what is best practice or recommended practice before you can start to do your change. The methods for doing this start, of course, with, let's say, dissemination, so pushing the information to target audiences. But this field has broadened quite a bit, and they also cover what they call pull strategies, which is that part of the effort could be to raise interest in target audiences in the research findings or in some sort of information. So it is that's not sufficient in many situations just to send messages about what is best practice. For instance, publish guidelines on a website. And nowadays they are easily made available to everybody, but you also have to consider how to raise interest in this. Perhaps by engaging the target audience in what you do. Then your question, what is the impact of all of this? The impact is not well studied, so the dissemination is less well studied than implementation, and it's mainly in terms of having seen a guideline or having understood what is the content of it, but it doesn't imply that if you if the guideline or a piece of information is well taken, is understood, it doesn't imply that it's also implemented in practice. The correlation between people who really want to change some aspect of their behavior and what they actually do is not very high. It's actually 0.3. It's not different from patients who try to stop smoking. Even if they really want to stop smoking, it's not easy for them to stop. So the same for physicians or nurses who have particular routines, and they often find it very difficult to change. So knowing what you have to do and understanding it completely doesn't automatically mean that you really change your practice. You have to usually to do more.
Okay, Ilona Autti-Rämö.
Yes, I worked in the field of rehabilitation my whole professional life, and it's possible to change the attitudes. It's fairly easy to change the way the professionals do if you have the research that supports it. But when it comes to the organizational structure, then you end up having the problems. Because it's not only about attitudes, it's about resources. If you have a fixed budget or you have fixed resources and you need to change the resources in a different way, then there are huge boundaries. Have you done any research on a field where you really need to have a replacement of resources or new resources in order to gain cost effectiveness in near future, but temporarily you need more resources to show that this can be implemented into your practice?
I absolutely agree that you need resources to make certain changes, even and sometimes permanent, and sometimes temporarily. I didn't explicitly study this aspect, but it is part of several programs that I studied. For instance, this program in Baden-Württemberg implies more money. And the people who participate tell you that this has been crucial, that they get more money for these patients because they have longer consultations and more consultations. As a researcher, of course, I believe them on the one hand. On the other hand, I'm not sure if it wouldn't work with less resources or that's not. And the problem is that this is one element, often one element of many components. More resources. So it's difficult to say, to answer your question, is there evidence showing that it is crucial or not? There is, of course, research on pay for performance or changes in reimbursement systems. There's actually a Cochrane review on changes in reimbursement systems, which summarizes several other reviews. And this clearly shows some impacts. It's very non-specific, so to say. If you change to from a capitation system to a fee-for-service system, or partly, so you pay for specific consultations or procedures, then more procedures and more consultations will be done. But whether this is good or bad, or that supports implementation of evidence-based practice, is less clear from those type of studies. So I can only partly answer your question, I'm afraid.
More research to be done. Jorma Komolainen.
Yes, thank you for a very exciting talk you gave. I have a point of view which might be a little bit stupid or ridiculous, but I will tell it anyway. I think we have a group of very successful implementers in the field of medicine or healthcare, and with this I mean pharmaceutical companies. Actually, when we talk about them, we are not talking about implementation, but marketing. So my questions are, what is the difference? What is the real difference, or what are the differences between implementation and marketing? And are there any common things with them? And then the second question is there something we should or could learn from the pharmaceutical companies?
Yeah, good question, of course. There's a lot in common, except the message is different. Marketing is usually to promote and sell a certain product, a medication or something else, or an information technology. And my focus is usually to implement something that's evidence-based, meaning that it is good for patients and populations generally. Or there's consensus, at least, that this is good for patients and populations. What we can learn is, of course, their approaches, or some of their approaches. A good example is already very old, academic detailing, which is visiting doctors in their practice to bring a certain message and promote this message, which is more or less copied from pharmaceutical industries who send in people to practices to promote a certain medication. This has been tested by Stephen Sumerai 30 years ago and shown to be highly effective at that time, and also later studies confirm this. And also more generally, there's not just within the field of marketing, there's a subfield called social marketing, and this is a field that is partly relevant and also partly similar, I would say, to what I described, because in social marketing there's also much emphasis on analysis of the target group, understanding their problems, adapting your approach to those problems and to the target group. So the general approach is very much the same, I would say. Of course, marketing, or let's say the strategies some of the firms have, are perhaps a little bit more difficult, or I would not recommend to take those on. If I think about the way certain very expensive drugs are promoted or have been promoted, at least in the Netherlands and also in Germany, I would not recommend to do this, because I would say this is would not be according to my ethical standards.
Okay, Karoliina Tuomisto. Oh, Karoliina Tuomisto up here, Mario up front, and then the gentleman in the back. I can't really see you. Yes.
Yes, thank you for the great presentation. I have a bit of a policy question, and the basic question is, are we implementing too much at the same time? Because I have a feeling that some of the negative results that keep coming out from these studies may actually be because we are trying to, especially in primary care settings, trying to implement too many specific programs at the same time, and they don't always have similar objectives. So is it that we are just implementing too much at the same time, and therefore we are not seeing good results from the different implementation of the programs?
Yes and no. I think, of course, you cannot do everything at the same time, and it may actually work negative. So I would recommend indeed to set priorities. On the other hand, this is also difficult because, let's say, you focus on antibiotics prescribing and you completely focus your improvement work this year on antibiotics prescribing. But then there are, for a general practitioner, 100 other topics, or perhaps not 100 that should be improved, but at least 10 others that should be improved, have equal priority. And so the challenge is to find a way that you try to learn and improve yourself continuously, not just in one particular area that may have your special expertise, and I don't know how to solve it. It's really a challenge. You cannot expect practitioners, or it would not be a good idea, to focus too much on a very narrow area, because there are simply different priorities. The other thing is that I would also emphasize, which was not the topic of today, but I would emphasize de-implementation. So the implementation of evidence-based practice implies occasionally that you have to stop certain things that are not so helpful for patients. And there are lots of things where the evidence is lacking, or the evidence is actually showing that it should not be continued, and it's still continued. And hopefully, or that would also create some more time for other things if you would do this. But a real solution, I don't have a real solution, of course. It's a tension between having to focus on certain priorities and, on the other hand, covering a broad range of things. But you cannot simply say, I focus on antibiotics and I don't do anything in geriatrics or for my older patients, because this year although I know there's a big problem there as well. So it's really a challenge.
Okay, now back there, where Mari stands. Can you please identify yourself?
I suppose there was another person before me. No, can I go?
That was, it's your turn now, please.
Okay, my name is Timola and I'm coming from the Finnish Institute of Occupational Health. I wonder, how do you feel about these ICT-based solutions? Because, you know, the experts they seem to be not following very well these good practice guidelines. And
which solutions? I missed that.
Sorry, the professionals in healthcare and other services may know that there is a good practice guideline on an issue of interest, but do not maybe often follow it in a way it should be followed. So how do you see a possibility to use these ICT solutions where you have a system that gives you guidance while you are doing your practice? We have a little bit some experience of this one. You know, also the AE type of solutions where you have your artificial intelligence guiding you through the procedures. Any science on this one?
Well, I would like to emphasize the original idea of evidence-based practice, which is that you take into account evidence from research, but you also take into account clinical experience, which is collected over periods of time by practitioners, and of course patient preferences, and perhaps also costs. The idea is not that guidelines or evidence have to be followed all the time. I have to say, secondly, that the measurement is usually very simplistic. We measure what decision has been taken and look at whether this is consistent with the recommendation, although not following a decision or a recommendation in a guideline may be perfectly legitimate. So the measurements are very crude, but in the end, I would be a little bit worried, and I also appreciate the role of professionals who take all these factors into account and do not follow evidence automatically, because then you could use a robot for many decisions. And the background of this is not only that they are nice people, but also because the information, the evidence is in many areas so limited that you cannot simply, that it's not easy to take decisions in a sort of automatic way. And there are exceptions to this, of course, but this will be my general response. So I'm support by information technologies, yes, but in the end there has to be a human decision, actually a patient and a provider together, ideally.
Okay, Marjukka Mäkelä.
Thank you. You started by some country comparisons on the style of implementing evidence, and I was thinking that where does Finland sit? I think we have actually a clan or a family style of evidence-based medicine, which is largely created with support from Duodecim and has a large element of education and involvement of practitioners. Now my question to you is there a classification on how evidence-based health systems are, or should we create one?
Well, there are efforts by John Levis from Canada to categorize activities that health systems or in health systems can take place to implement evidence. And this ranges from creating research that is relevant for people in practice and for patients to, let's say, initiatives to create an interest in the findings of research, because you can do fantastic research, but if nobody is interested in research at all, because it's not part of the professional development, not part of your profession to take research into account, then it will always end nowhere. So, and there are a range of other activities, but let's say what you suggest, a taxonomy of health systems, I'm not aware of it. I don't think it exists, so that could be another idea for future work.
Now I don't see any hands, and I'm still thinking about the differences between the health systems and maybe the behaviors of the health professionals and the total context. I'm not sure if I can really formulate this well enough, but I'm wondering about our ability to and the helpers and hinderers of transferring evidence from one country to another. and implementing that sort of foreign evidence. Would you like to comment on that?
Yeah, that's of course always an issue. Evidence that is generated in a particular setting, is it applicable to a different setting? And it is easier when it's in the biological field, if the assumption can be that the human biology is the same in a different setting. This is sometimes also an issue, but let's say it's even more difficult when it comes into a behavioral field or in social care. And it's usually partly yes, partly no. I don't take the view, I don't think it's very fruitful to say that everything is unique, and so all research outside Finland does not apply to you. That's one view, and of course there's always something unique. There's probably something unique in Finland too, but I don't think that's a very good idea, and it's also not fair. But on the other hand, you have to acknowledge that there are probably elements in the population, in the tradition, and also in the healthcare system and in society that are different from other countries, or perhaps you are in a group of countries with certain characteristics which you do not share with, let's say, North America or so, where many studies are actually done, because if you do research and you do a review of studies, usually at least half of the studies is from the United States. So it's usually the question comes down to the point, is this study or body of evidence from the United States, for instance on chronic disease care, relevant for me in Europe? And yeah, United States has a very different healthcare system, very different tradition compared to our countries. So it's usually partly yes, partly no, and it's a matter of judgment. There are actually some suggestions, some, let's say, checklists that help you to make this assessment systematically, but in the end, it's a professional judgment you have to make.
Yeah, I would go for that there are more similarities between us people in different countries than differences, biologically or not, but anyway. So, thank you very much. Let's give Professor Wensing a nice hand